Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. We're here at the ECW Enterprise Summit, and our guest today is Eileen Testa. She's administrator at 9th Street Internal Medicine Associates. Welcome, Eileen.
Thank you. I'm happy to be here.
Yeah, excited for this discussion. So tell us a little bit about yourself and 9th Street Internal Medicine Associates.
Okay, thank you. I've been in healthcare for 40 plus years, maybe a little longer. Started out as a file clerk part-time in high school at a physician's office, and worked my way up through the ranks, and while putting myself through Temple University to get my degree. And over the years, I've just done pretty much everything and anything you can think of in a practice. Billing, medical assistant, managing, and now I'm an administrator at 9th Street Internal Medicine, which is a pretty good size practice. We have about 13 providers, about 45 staff, and we're located in Center City, Philadelphia, and we're privately owned. Okay. So we're probably one of the largest privately owned practices in the city.
Yeah, the only that remain, it seems.
Yes, yeah, we are a dinosaur.
That's awesome. Yeah. Well, and it's amazing you have such a depth of experience, and I bet you've seen an interesting evolution when it comes to population health tools within ECW, and even how did we do population health before these tools, but talk to us about your experience with these tools.
So absolutely. Back in 2007, we decided to apply to become a patient-centered medical home. Okay. And in order to do that, we got into the population health realm. Mm-hmm. And to do this, you had to look at care gaps for patients and pay attention to the different modules of what we needed to do. And at that point, ECW was not quite there with their population health tool. So we ran registries. Okay. And they were a long process, and they were very convoluted, and they would take days to run. But we did them, and it worked out well. And over time, eClinicalWorks heard us and said, we got you. We're coming, we're coming, we're getting there, we're getting there. And they did, and they created these HEDIS dashboards, and they've been phenomenal. And now I can drill down by provider, by insurance company, and I can do all kinds of wonderful things with these dashboards.
That's awesome. So is really the key is those dashboards that get you to the data? Is that the key tools that they're offering you?
Absolutely. I mean, we can get data from the payers. Any payer can send me a spreadsheet or information that says, here are your patients with key gap, information, but it's not accurate, because theirs is based on claim information. And if the patient had changed insurances somewhere in the middle of their time there, they don't have all the data. I have all the data.
You already have it.
I know it, and I've got it. So I like running my reports. I like looking at what we do.
Yeah, that's interesting.
Our population health team has a great process for how we handle it.
Yeah. Well, talk to us. You mentioned the HEDIS dashboard. I mean, it's such an important tool for so many organizations. How has that kind of evolved over the time you've used it?
They've made it easier to drill down, so I can run it by payer. I can run it by provider. It's not just looking at the colon cancer screening in a big vacuum. I now can look at it in a much smaller, little pieces of it.
Interesting. And then do you take that data and give it to care managers, or how do you approach the data? I mean, I think it's one thing to get the data. Absolutely. They showed some interesting tools here at the Enterprise Summit where you can now natural language ask for the reports. That's fascinating.
It's so exciting. I was almost hyperventilating today listening to the new tools that are coming. I was like writing down notes feverishly. Yes, I can't wait till this happens. But yes, it really does matter how we get this. So I look at these reports, and I can run, each month we pick a different care gap. And so this month, for example, is diabetic retinopathy. Okay. So our team runs the reports by provider for patients who need an eye exam. And so we give each of our nurses that work specifically with that provider a list of their patients that are lacking in that gap. So they can look at that, and they can try to look through Prisma or other data that we get from other health systems and things like that to see if we've gotten the report. We just have it downloaded into our system. Sometimes we get the report from an ophthalmologist, but maybe our scanner didn't label it correctly. So we have to look, and we do a little research. So after that's done, then they actually go through and say, you know what, no, this patient absolutely positively needs an appointment to get one done. We have a camera in the office. So we call the patient to try to schedule them for an appointment. If they've had diabetic retinopathy in the past, clearly we can't do it, but they've got to see an ophthalmologist, we call and try to get them scheduled with one. But that's the process. And next month it'll be mammogram, and the month after that it'll be something else. So we work on these lists every single month to get our gaps down.
That's impressive. I mean, it's interesting to think when, over this time, that mindset has changed, right? I mean, 30 years ago, were we doing this type of proactive?
No.
And where do you see that heading, as far as it's really value-based care at the end of the day?
It's completely different. 30 years ago, when I was a medical assistant, I was no more than an usher in a theater. I'd walk the patient to the room, say, have a seat, and the provider will see you shortly. Now, it's totally different. My clinical assistants are pre-charting. They're looking at the CDSS alerts. They're verifying what the patient needs. They're ordering things ahead of time. They're ordering the mammograms and the colons, cancer screenings, and whatever needs to be done before the provider gets into the room for the patient. We also have tools in place where we can say to the patient, listen, if you really don't want to get a colonoscopy, I understand that. How about if we order you a fit test or a Cologuard? We are proactive in that way with our patients. But yeah, that never happened 30 years ago.
Well, and in many ways, we didn't have the data to do it.
Correct.
Unless you wanted to search through the paper charts, which they only did for research.
Oh, heavens to us. No, they were horrible, the paper charts.
Yeah, for sure. That's interesting. Well, another topic that I think be interesting to hear about is kind of the whole payment services. And we know there's been a huge increase in patient payment because of high deductible plans and other things like that. What's been your experience? Because you implemented the HELO payment services. How has that gone for you?
It's gone really, really well. We turned it on probably last 6 or 8 weeks, I'd say. And based on the information that we've done then, it's been phenomenal. Our revenue for the first 18 days of May is already double what we got in April.
Wow.
Or, March before that. I can't count backwards.
Yeah.
But yes, we're showing a big increase. We created a little widget on our website that says pay your bill here. Our staff is really good at calling the patients, or the patients call us and say, I got an electronic statement, and I'd like to pay. If they don't want to click and pay there, sometimes they have that ability to just call and say, what's it for? So we can say, well, we can take your credit card payment right here. They open up the account, they click on the $sign, and we take the credit card payment right then and there. We didn't have that ability a while ago.
Wow.
And I could already see the change in revenue.
Yeah, I mean, I think that's one of the key changes is that we didn't care about patient payment because we were receiving so much for the insurance companies, right?
Yes.
But now that's shifted where it's like, okay, now the patient payment matters.
Right. And one of the things I'm looking forward to is turning on the text to pay so that if I schedule an appointment for a patient for a telehealth visit, that they'll get a reminder that you have a telehealth visit on Thursday with Dr. X, and you have a $25 copay. Would you like to pay that now? Click here. That's going to be huge, because then I will also decrease my no-show rate for that appointment, because they're less likely to not show up for that telehealth.
Paid the copay.
Correct. Correct.
Wow, that's fascinating to think about. Yeah. And I'm with you, right? Like the easiest way for me not to pay a doctor's bill is to send me a piece of mail.
Right.
The easiest way is send me an email or text.
I just got a text while I was, a few minutes before here that I owed my dentist appointment for, previous dentist visit, and they sent me a text, click here to pay. It works.
It does, for sure. Well, Eileen, I appreciate you taking the time to share these insights and perspectives and your experience. It's always great to learn from people on the front lines. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcast applications. Thanks, Eileen.
Thank you.